really a star in the academic field of Calcutta. He passed MBBS from NNS Medical College, then passed MD from then Calcutta University, then joined MES, and he is the professor of tropical medicine. I think he is serving this institution for more than 30 years, acquired both knowledge and hype. He is now authority in tropical medicine, which at a time pride of Calcutta. Now about the subject, that unconsciousness in immunocompromised is a very common phenomena. It may occur due to infection, due to some metabolic problem, or due to some neurological cause or drug toxicity. All are important. I think Professor Dipanjan Bandyopadhyay will do justice to the subject. Now hand over mic to Professor Vibhuti Saha to continue the meeting.
Thank you, sir. You have kindly introduced the subject. And to talk to us is none other than Professor Dipanjan Bandyopadhyay, with whom I have been associated in the academic exercises for a long time. I remember Dipanjan was in charge of the Apex Clinic of Medical College, and we had been to many places. We have taken TOT training of faculties for fellowship in HIV medicine at CMC Vellore, and we had been there with many occasions. And Dipanjan is one of the key persons in HIV medicine today all over India. He is known for all his excellent activities and talks. So I think Dipanjan will take to us to the story of altered consciousness in immunocompromised patients. Immunocompromised patients, we know that they can be due to various causes, including HIV disease. And so over to Dipanjan for his talk to all of us and enlightening all of us on the topic.
Good morning, all seniors and juniors and dear PG students. At the outset, let me thank API West Bengal for this opportunity. It is always a pleasure to come to the API West Bengal platform. What we shall be discussing this morning is how to deal with, or what are the diagnostic considerations to keep in mind when we encounter altered sensorium in the immunocompromised host. And before I proceed, let us clarify that we will be discussing, when we talk of immunocompromised host, we will be discussing patients with retroviral disease, but this can broadly be extrapolated to the immunocompromised hosts that we see in the setting of maybe chemotherapy or transplant recipients. So with these few introductory words, let us try to move the screen. I bring you greetings from North Bengal, which is now possibly as hot and humid as South Bengal. And we remember at the outset that like rabies or like some human herpes viruses, HIV per se is a neurotropic virus. So the neurotropism of HIV leads to early involvement of the neuroaxis, and a direct viral infection of the neurological cells is seen from the outset of HIV infection. So all the immune deficiency driven opportunistic infections, the AIDS-defining cancers, ART-related neurological side effects, vascular events because patients are living long, all come sequentially after HIV per se has possibly invaded the neuroaxis. We were taught when we were initially learning the science and art of HIV that when it comes to the neurological manifestations of HIV disease, we can broadly classify the cerebral affection into focal or global cerebral involvement. So looking at this slide, I hope you will appreciate that all your space-occupying lesions will give rise to focal neurological signs and scenarios. In contrast to the more diffuse or global neurological involvement, where features like encephalitis, encephalopathy, cognitive impairment, impairment of higher functions, they will come into the picture. Followed by these two cerebral syndromes, we have issues like meningitis, we have myelopathy, we have radiculopathy, we have neuropathy, and last but not the least, we have retinitis, which is also part of the neurological system. So before we leave this slide, it is important to remember that acute seroconversion illness, which is the earliest stage of HIV infection, can also lead to neurological manifestations in the form of aseptic meningitis, in the form of something like AIDP or a GB syndrome-like picture, and they can also lead to sequential manifestations in the form of various opportunistic infections. So with this introductory note, let us have a word on the emerging epidemiology of neurological disease in HIV. Majority of the patients with advanced HIV will have some sort of neurological involvement. And with the increasing access and the availability of combined antiretroviral therapy, chronic neurological conditions are becoming more frequent. The HIV population is aging, and long-standing HIV-related issues like cognitive dysfunction, cerebrovascular disease, peripheral neuropathy, etc., these degenerative conditions are becoming more and more frequent. We now have a wide array of antiretroviral drugs, and because of the prolonged use and prolonged survival of our patients, the neurotoxicity of these antiretroviral drugs are also coming into the differentials and coming to the forefront of our clinical discussion. Now, HIV infects neurons, but they do not proliferate in the neurons. So the neuroaxis is basically a storehouse of HIV virions. What actually proliferates the virus are the monocytes and the lymphocytes, which are the inflammatory cells. They differentiate into resident macrophages, and these activated monocytes and macrophages produce a series of chronic inflammatory reaction where there is migration of inflammatory cells and there are altered concentrations of neurotransmitters. We have seen and we have learned and we have read that there is a preponderance of excitatory neurotransmitters in relation to the HIV, chronic stages of HIV infection. So HIV infection and neurological manifestation can basically be classified into, as we were discussing, primary HIV infection, manifestations secondary to OIs, immune reconstitution syndromes, which now our juniors possibly recognize as much as we do, and manifestations associated with antiretroviral management treatment. Last but not the least, today we shall be discussing on the cerebral dysfunction because our topic is altered sensorium in the immunocompromised host. But even beyond the cerebrum or the brain, we have the spinal cord, the meninges, the nerve roots, peripheral nerves, and even muscles which can be affected by HIV or its associations. Repeating acute seroconversion illness, aseptic meningitis has a strong correlation with CSF viral load. As I mentioned earlier, initial HIV infection has a high viral load in the circulation because that point of time, the immune system is yet to mount the response to the virus. And because of this high viral load, there is viremia in the CSF. And viremia in the CSF, viremia in the blood, all leads to a large chunk of the viruses reaching the neuroaxis. And especially in resource-poor settings like ours, where we do not have access to virological tests or tests like the P24 assay, we seldom diagnose acute HIV illness because we depend on the antibody mechanisms of our diagnosis. So there is a limited ability to diagnose acute HIV infections in countries like ours. And we often miss these syndromes of viral fever, viremia, aseptic meningitis, AIDP. We can have transient thrombocytopenia. It can lead to a presentation like ITP. And these are basically all transient manifestations of acute seroconversion illness. CNS affection of HIV can broadly be divided into meningitis, of which tuberculosis tops the list in a country like ours, although cryptococcal meningitis is the topmost etiology when it comes to meningitis in the immunocompromised host. Syphilis is making a comeback, possibly with better control of HIV infection, so which is the rule of epidemiology. So nowadays, once again, we are getting patients who are suffering from secondary or tertiary syphilis, especially with concomitant HIV infections. The most interesting part of the HIV story in CNS manifestations are the focal cerebral lesions. We have a wide array of them, which we will discuss over the next couple of minutes. It can range from tuberculoma, moving on to toxoplasmosis, which is the commonest intracranial space-occupying lesion in the setting of HIV. We have PML, we have primary CNS lymphoma, there can be neurocysticercosis, and even iris or immune reconstitution syndrome can manifest as multiple focal intracerebral space-occupying lesions, usually of the tubercular etiology in a country like ours. Coming to encephalitis or encephalopathy, we see less of this, especially because there is less diagnosis of viral diseases, but CMV again can affect the neuroaxis. The more common sites of CMV neurological affections are the spinal cord and the radicals. So we have either radiculopathy or myeloradiculopathy. We can have herpes simplex virus encephalitis, and toxoplasmosis can cause both focal cerebral syndromes or a global cerebral syndrome. Coming to myelitis, I had the good opportunity of speaking on vacuolar myelopathy at Epicon New Delhi this year. And apart from vacuolar myelopathy, which is the manifestation of HIV infection per se, we can have myelopathy related to CMV, herpes, syphilis. And we have seen, I could not get the photograph, we have seen myelitis in our wards and even before of spinal toxoplasmosis and spinal cord tuberculoma. Last but not the least, we have grown up with the concepts of AIDS dementia complex. We have talked of ADC to our students in earlier days. Today, the nomenclature has changed, and today ADC is better known as HIV-associated neurocognitive disorder or the HAND syndrome. So coming to altered sensorium in HIV, altered sensorium in HIV, we can have these opportunistic infections. We can have CNS neoplasms, not only in the form of primary CNS lymphoma. We have seen neurological affection with high-grade diffuse large B-cell lymphomas, and high-grade diffuse large B-cell lymphomas are an AIDS-defining diagnosis. When it comes to immune reconstitution syndrome, the CNS is one of the most commonly involved systems, and we will have a few words on drug-induced manifestations of neural manifestations of HIV disease. Again, this is a very old and almost an undergraduate slide, but it is important to remember that as the CD4 cells goes down and as the course of HIV infection prolongs, we have gradually progressive occurrence of various opportunistic infections. First and foremost to remember is that tuberculosis in India is hardly an opportunistic infection. We don't need to be HIV positive to acquire tuberculosis in India. So TB is seen in any CD4 counts, and in HIV domain, it is usually seen across the entire spectrum of CD4 values. As we come down, CD4 less than 200, we encounter more of PCP, histoplasmosis, cryptococcosis, and toxoplasmosis, classically around CD4s of 100. And if you go further down to CD4 of 50, you have the changing profile of opportunistic infections, where you have cytomegalovirus disease and Mycobacterium avium complex, or the non-tuberculous mycobacteria, which comes into the picture. So, these are some of the diagnoses that we will now touch upon individually. And this is one slide we can afford to remember, because most often than not, these are the diagnoses that we will be encountering when we deal with altered sensorium in the setting of HIV infection. We all know that, like diabetes and tuberculosis, HIV and tuberculosis are a deadly duo or a bad combination. And we need to remember that both TB and HIV influence each other. So the effect of tuberculosis and HIV enhances its susceptibility to viral infection. A TB infected person has increased rate of HIV replication, and the tuberculosis co-infection accelerates HIV progression, particularly in the ART-naive patients. Going on the reverse direction, if the person is HIV infected, the influence on TB is phenomenal. The transition from subclinical to clinical tuberculosis, the reactivation of latent tuberculosis, the relapsing tuberculosis, chance of death due to tuberculosis, all increases with HIV disease. However, what is most important for our clinicians to remember is that HIV does not affect TB treatment failure. We can go ahead with the usual national tuberculosis program, and it does not increase the chance of MDR-TB. We have the misnomer that TB with HIV is equal to MDR, which is actually not. Although MDR is increasing in India, and today again our juniors are more oriented to CBNAT and resistance testing, which we were not having access to in our times, it is important to remember HIV per se is not a risk factor of MDR-TB. CD4 less than 100, tuberculosis goes more extrapulmonary, more disseminated, more rapid progression. And the chest X-ray resembles more of primary TB. What do I mean when I say primary tuberculosis? Usually we see tuberculosis on the chest X-ray as a focal involvement. We have all grown up with the concept that tuberculosis affects the upper lobes of the lung. But when it comes to low CD4 counts, this transforms itself into primary tuberculosis infection, which is seen more often in the pediatric setting. But the most important issues with tuberculosis when it comes to our altered sensorium setting is a tuberculoma, which again we need to remember is a function of good immunity. So we usually don't see a tuberculoma at very low CD4 counts. Tuberculoma itself denotes that there is ongoing immune reactivation or immune action against the tuberculous bacillus. Tuberculoma is usually associated with a large perilesional edema, often with midline shift, usually single. In the setting of iris, there can be multiple tuberculomata. We have seen an entire starry sky appearance on the CT scan and the MRI, where we had tuberculomata spreading all over the brain following introduction of antiretroviral therapy in earlier days. So these are all the various forms of tuberculoma which we need to suspect, and these are all the differentials which will be coming up in the course of our discussion. You can see the large amount of perilesional edema which mandates steroids. There are very limited indications of steroids in HIV, of which this is one, where you need to control the edema even before your ATD starts acting, because this edema itself can be life-threatening. And of course, you need supportive management in the form of anti-epileptics and etc., etc. This again is a very classical picture of basal meningitis, where you have extensive and severe arachnoiditis. So these are usually seen at relatively higher CD4 counts. And when it comes to low CD4 counts, a tubercular meningitis usually occurs with disseminated or multi-organ affection of tuberculosis. The other causes of meningitis, as we were mentioning, could be bacterial, which in the general hospital setting is not much increased as compared to the immunocompetent population. We can have aseptic meningitis, which we were talking about, and possibly the most important entity would be cryptococcal meningitis for you and me to remember. HIV itself or by other opportunistic viral infections can cause aseptic meningitis. Usually they follow the classical features of meningitis, headache, malaise, fever, etc. But then there are more non-specific constitutional features associated with this illness. There can be skin eruptions if varicella is the culprit. The typical CSF profile in aseptic meningitis is, as we know, of lymphocytic pleocytosis, mildly elevated CSF proteins, normal glucose concentrations, and negative microbiology tests at the bacteriology laboratory. Coming to cryptococcal meningitis, this is one of the most common opportunistic fungal infection in the immunocompromised host. We have two species, of which neoformans and the subspecies neoformans, variant neoformans is the one which we encountered more in the Indian subcontinent. In the Central Americas, we have more of Cryptococcus gattii infection. Cryptococcal antigenemia is considered an independent predictor of cryptococcal meningitis with advanced immunosuppression. And even in this age of potent and capable antiretroviral therapy, we have a significant amount of mortality related with cryptococcal meningitis. This is a pretty old diagram, but it basically conveys the burden of cryptococcal meningitis across the globe. And you can see that we at the right-hand bar, we in Southeast Asia come second only to sub-Saharan Africa in the preponderance or prevalence of cryptococcal meningitis. Essentially, what is important to remember is the clinical picture of subacute meningitis. The classical picture of bacterial meningitis might be missing. There can be fever and headache, but neck stiffness is less common than in bacterial meningitis or the classical TB meningitis that you and I see. And as the disease progresses, there is more neurospecific manifestations develop, including mental alteration of mental status, classical neck stiffness. There can be cranial nerve involvements. And this is again one of my very favorite and old slides, which I managed to lay my hands on yesterday night. But then you can see the duration of illness is almost 2 to 4 weeks. So you basically have a subacute course of infection. And neck stiffness is less than 50%, CD4 less than 100, more common. There can be disseminated cryptococcal disease in the form of pulmonary infection as well. Diagnosis of cryptococcal meningitis should be very high on the list of our clinical suspicion. Any patient who is immunocompromised, even in the setting of organ transplant or chemotherapy, we must consider cryptococcal meningitis. India in preparation, the standard age-old Indian preparation yields a positivity of 60 to 70%. A very high opening pressure when we perform the lumbar puncture, a guarded lumbar puncture, a safe lumbar puncture, a very high opening pressure should be the clinical pointer to the diagnosis of cryptococcal meningitis. Again, this is a slide from my old collection, and you can see that a positive CSF Indian preparation is less sensitive. Today, our students and our juniors have access to cryptococcal antigen testing in the CSF, and you can see the sensitivity of picking up the diagnosis is far higher when you use the cryptococcal antigenemia. Anyway, coming to the some details about this cryptococcal antigenemia. Screening for cryptococcal antigen has been proposed for preemptive antifungal therapy among cryptococcal antigen positive people to prevent the clinically evident cryptococcal disease under the national program. We do not routinely follow this recommendation, but a person with CD4 count less than 200 is eligible for a screening test of cryptococcal antigen and receiving a therapy which is a preemptive therapy for cryptococcal disease. And the preemptive therapy is basically a 10 weeks course of high-dose fluconazole followed by a low dose fluconazole of 200 milligrams until there is evidence of immune reconstitution in the form of CD4 counts more than 200 for more than 6 months. So this is a preemptive antifungal treatment which we do not routinely follow, but the treatment of cryptococcal meningitis across the board is now well known amongst the clinicians. The traditional preferred regimen was a combination of amphotericin B with flucytosine. We have now moved on from amphotericin B deoxycholate to liposomal amphotericin B, and due to the non-availability or difficult availability of flucytosine in the Indian context, we follow what is mentioned as alternative 2 in this projection, where we have 2 weeks of amphotericin B and high-dose fluconazole, followed by the consolidation phase of fluconazole for another 8 weeks. So 2 weeks combination therapy of amphotericin B plus high-dose fluconazole, followed by 8 weeks of consolidation phase of fluconazole. And this 10 weeks therapy is standard, followed by the maintenance of secondary prophylaxis till immune reconstitution. When do you discontinue fluconazole maintenance treatment? As secondary prophylaxis, for secondary prophylaxis, you need to ensure good adherence to ART. You need to ensure the fluconazole maintenance. You need to see that the CD4 cell count is more than 100 and the plasma viral load is suppressed, following which you can discontinue secondary prophylaxis with fluconazole. Other than antifungal therapy, one important issue in the domain of cryptococcal meningitis is the high opening pressure, which can lead to neurological complications. So there is this concept of therapeutic lumbar puncture, where we do daily lumbar punctures, sometimes alternate day lumbar punctures, and we reduce the intracranial hypertension, intracranial pressure by allowing the fluid to drain out. So once we have detected that the opening pressure is high, if on the ophthalmoscopy, if you find that there is evidence of raised ICT, and if the patient is in altered sensorium, which goes more in favor of a raised ICT, then we need to reduce the CSF pressure. If the person initially has focal neurological deficits or serial puncture, lumbar puncture, removal of CSF fails to control the increased ICP, a lumbar drain or ventriculostomy may be indicated in some special settings. Coming to the issue of liposomal amphotericin B, we are all using liposomal formulations for our leishmaniasis cases, albeit the gross reduction in leishmaniasis over recent years. What we need to remember is that even the liposomal formulation should be used carefully, reconstituted, administered within 24 hours of reconstitution, infused slowly, and should be supplemented with oral potassium and oral magnesium because of the concomitant hypokalemia and hypomagnesemia associated with liposomal amphotericin B. If there is one opportunistic infection that we need to remember, other than tuberculous meningitis and cryptococcal meningitis, that should be Toxoplasma encephalitis in the setting of PLHIVs. The transmission cycle occurs by eating food which is contaminated from cat feces. It is the most common cause of focal brain lesions among the PLHIV. Clinical disease rare if the CD4 count is higher and there is no human-to-human transmission recorded. So essentially, what is the clinical feature? It's a feature of focal encephalitis, headache, confusion. There can be focal neurodeficits. Patient can be febrile. There can be non-focal manifestations, non-specific headache and neuropsychiatric symptoms. In the absence of treatment, there is progression of disease to lead to seizures, coma, and death. The classical diagnostic feature is multiple contrast-enhancing lesions, bilateral, more in the gray matter or at the junction of the gray-white junction, and often associated with significant edema. A single brain lesion with diffuse encephalitis can be a manifestation, but for the PGs, multiple intracranial space occupying lesions is toxoplasmosis unless proved otherwise. So these are some of our old collections, and the diagnosis basically essentially is a clinical diagnosis. serum IgG or IgM does not indicate active disease. And usually CNS toxoplasmosis is a reactivation illness. So IgM is not helpful for the diagnosis. Elevated serum IgG or basically elevated CSF IgG has high specificity for the diagnosis. And as we mentioned, lesions are usually enhancing and they have a predilection for the basal ganglia. So this, I think, is a list which we need to remember at the end of this session, that intracranial space occupying lesions in PLHIV can be tuberculoma, toxoplasmosis, a brain abscess. A brain abscess can be fungal, it can be tuberculous, it can be non-tuberculous microbacteria. Nocardiosis can be a cause of brain abscess in HIV, fungal granulomata, and primary CNS lymphoma. So these are some of the common intracranial space occupying lesions in the setting of HIV. Again, you see bilateral involvement, huge perilesional edema. The first diagnosis, of course, has to be CNS toxoplasmosis, but then there are some atypical features on this neuroimaging cut where you have more involvement of the periventricular areas, so which we shall be discussing in the subsequent slides. Now, if here you see again less amount of edema, periventricular affection, and these are telltale pointers of primary CNS lymphoma. So primary CNS, which we will come to. But then this is the management of toxoplasma encephalitis. The preferred regimen is a combination of pyrimethamine and sulfadiazine. Again, thanks to our seniors like Vibhutida and Shubhashishda, we have learned alternatives in the absence of pyrimethamine in the market. So basically, we have used cotrimoxazole as alternatives to the pyrimethamine sulfadiazine combination. But then pyrimethamine plus clindamycin is a valid combination in this, especially the setting of sulfur allergy or intolerance of sulfur drugs. So pyrimethamine plus clindamycin can be used, or a course of cotrimoxazole is the standard care that we offer for patients of toxoplasma encephalitis. Coming to cotrimoxazole prophylactic therapy, CPT protects from multiple diseases, PCP, toxo, other bacterial diseases, some of the opportunistic diarrheas like isospora. All these are protected by cotrimoxazole prophylaxis. The double-strength tablet once daily is the standard of care. In case of allergy to cotrimoxazole, an alternative for primary prophylaxis can be dapsone, and desensitization of the sulfur drug may be suggested because cotrimoxazole is such an important value addition to our HIV care regimen. Again, this is a beautiful photograph. This comes from one of my Kolkata collections, and you can see multiple brain abscesses on either side of the midline. And again, this could be anybody's guess, but then nocardiosis could be a possibility. This was one of the rare cases where we had histoplasma on brain biopsy of this patient who went to South India for a treatment. CMV-mediated neurological disease. Classically, when we talk of CMV, we talk of retinitis because CMV retinitis is the most common ophthalmologic manifestation of HIV. But apart from retinitis, CMV can affect the GI tract in the form of esophagitis. CMV can cause colitis, and CMV, of course, can involve the neurological system in the form of dementia, encephalitis, polyradiculopathy, and polyradiculomyelopathies. CMV polyradiculopathy causes a lower motor neuron type of weakness that is characterized by urinary retention, progressive bilateral lower limb weakness, and which is classically, as I said, of the lower motor neuron variant. So this is CMV retinitis, which also comes in the neurological domain, not with altered sensorium, but this is something which we need to understand. A hemorrhagic retinitis in the appropriate clinical setting is CMV unless proved otherwise. Progressive multifocal leukoencephalopathy is relatively rare, especially in the era of active antiretroviral therapy. So PML is a viral infection, as we know, caused by the JC virus. The virus itself is very difficult to identify. Immunosuppression classically occurring in the setting of advanced HIV disease or in the setting of advanced cytotoxic chemotherapy, which leads to the depletion of our T-cell mediated immunity. They cause reactivation of this virus, resulting in neuroinvasion, oligodendrocyte destruction, and a debilitating demyelinating illness. The incidence rate has gone down. These figures are older figures, and today I don't think many of our juniors will ever see a case of progressive multifocal leukoencephalopathy when we are treating HIV upfront, irrespective of the CD4 counts. The manifestations can be focal or global. The demyelinations can involve various regions of the brain. Sometimes it can be mistaken for an evolving stroke, and headache and fever are not characteristic of the disease because there is less active or acute inflammation. So basically, headache and fever, when present, should indicate another opportunistic infection rather than progressive multifocal leukoencephalopathy. Imaging, there would be hyperintensities on T2 weighted and FLAIR images. No mass effect or displacement of the normal structures is again one of the clinical clues to the diagnosis of PML. We don't have access to brain biopsy in our hospitals or in our clinical settings. So imaging features are important. But then PCR of CSF sample for the presence of JC virus DNA is something which is more theoretical but can clinch the diagnosis. So these are some of the ways PML appears, and you can see there is hardly any edema and absolutely no midline shift or shift of the structures. No effective antiviral therapy. Effective antiretroviral therapy is the sine qua non of management. Worse prognosis associated with high plasma HIV RNA levels, poor response to ART, and brainstem lesions. They are often complicated by clinically significant iris that may require the administration of corticosteroids. So, reviewing the imaging in HIV-related neuropathology, HIV encephalopathy would look more like diffuse cerebral atrophy or diffuse cortical atrophy with or without basal ganglia calcification. Toxo would look like multiple ring-enhancing lesions. Tuberculoma, more often single ring-enhancing and usually associated with some degree of meningitis. And PML would be single or multiple hypodensities in the cortical white matter without contrast enhancement or mass effect. So this is basically a sort of a summary slide on the CT and HIV-related neuropathology. I was talking about HAND, which is a relatively new nomenclature. It is basically the neurocognitive impairment of an HIV-infected individual. In the era of effective heart, advanced dementia is rare. We have patients with mild neurocognitive impairment. Comorbid disorders contribute in the form of hypertension, diabetes, subclinical strokes, but they do not fully explain. So basically, it is essentially a direct HIV-mediated disease, although issues like viral load and CD4 are not appropriately correlated. So essentially, HAND is a long-term consequence of HIV infection. We know that HIV virus is not eliminated from the body. So there are repositories in the body where the HIV virus survives despite antiretroviral therapy. The nervous system is one of the major repository sites, and the consequence of this silent stay in the neurological system is HIV-associated neurocognitive disorders. I will not go into the details, but then HIV-associated neurocognitive disorders are classified into 3 stages: asymptomatic, minor, and HIV-associated dementia or HAD. So asymptomatic neurocognitive impairment is essentially subclinical. Minor neurocognitive disorder is what we see in our clinical practice. And this again is somewhat correlated with the duration of the HIV illness. HIV-associated dementia would be a significant decline in cognition along with a significant degree of functional impairment that affects the quality of daily life. This is a very classical MR plate of neurocognitive impairment. You can see ventriculomegaly, you can see cortical atrophy. There is no space-occupying lesion, there is no edema, there is no midline shift, but this is the classical picture of HIV-associated neurocognitive disorder where there can be neuropsychiatric manifestations, because when we learned AIDS dementia complex was more than dementia. So we could have altered sensorium and altered personality features in HIV-associated neurocognitive disorders. So prominent white matter changes throughout the brain, typically seen in more advanced disease and rare in the era of combination ART. Again, HIV-associated dementia, more likely with less CD4 counts. It's a diagnosis exclusion. I would like to spend 30 seconds on the last point in this slide. ART, we all know, is the most effective treatment for issues like progressive multifocal leukoencephalopathy or HIV-associated neurocognitive disorders. But then, if we are suspecting such illnesses, we should try to incorporate ART molecules which have better CNS penetrations. So we have this classification which I did not project, but then these are the drugs like zidovudine, stavudine, abacavine, nevirapine, lamivudine, efavirenz, and tenofovir, which have better CNS penetration and could achieve better functional outcomes in the domain of diseases where viral implication of the nervous system or viral involvement of the brain is the main pathogenesis. Coming to primary CNS lymphoma, again, it is a rare diagnosis, although it is the second most common mass lesion in AIDS worldwide. Why worldwide it is the second most common? Number one, tuberculosis doesn't affect the Western population as commonly as it does in our country. And number two, because of a prolonged survival of HIV patients, we are seeing the non-communicable consequence of HIV nowadays. So we have HIV patients with cardiovascular mortality and morbidity. We have HIV patients with osteoporosis. And similarly, we have HIV patients with more of AIDS-defining cancers and cancers associated with HIV infection. So, although opportunistic infections have gone down over the years, these consequences have not been controlled adequately. And as you can read, that primary CNS lymphoma still remains an important entity. The important issue to remember is that of all the virus-mediated malignancies that we talk about, like hepatocellular carcinoma and nasopharyngeal cancer, primary CNS lymphoma is almost always associated with Epstein-Barr virus infection. A CSF analysis where the EBV PCR is negative almost rules out primary CNS lymphoma. And as a continuation or extrapolation of this, CNS toxoplasmosis will have EBV viral PCR negative and IgG toxoplasma positive. So these are the two markers of diagnostic markers. Patients can present with lethargy, confusion, memory loss, headache, etc. There can be neurological manifestations of global cerebral syndromes, and there can be patients who develop cranial neuropathies and or ocular involvement. The CT or MRI would show periventricular lesions, and this is again a very important point to note. A periventricular location without much of edema, without much of perilesional enhancement would point to a diagnosis of primary CNS lymphoma. The interesting part of this story is there would be no lymphadenopathy in the patient. So the lymphoma is essentially restricted to the central nervous system. And as I said, lymphoma is suspected when the toxo IgG is negative or there is failure to respond to empirical treatment for toxin. There is no cytotoxic chemotherapy for the disease. And again, primary CNS lymphoma deserves efficient antiretroviral therapy. This is again a very classical picture of primary CNS lymphoma. No edema, no enhancement, and the location is classically periventricular, usually unilateral. Bilateral lesions would again point to toxo or maybe tuberculosis in the lesser perspective. Last but not the least, a few words about neurosyphilis. Not that we are seeing neurosyphilis very commonly in our clinical practice, but the neurosyphilis can be asymptomatic. The diagnosis would often be missed. But when we are performing our CSF analysis, I keep on telling my juniors, we should send for a CSF VDRL, especially if the CD4 count is low, or for that matter, CSF VDRL should be performed for all HIV patients whenever we are accessing the cerebrospinal fluid. The second manifestation could be acute syphilitic meningitis, which occurs within the first 2 to 3 years of infection. Patients can present with headache, meningeal irritation, cranial nerve palsies, etc. and they are often diagnosed at the time of the secondary, of the rash of secondary syphilis. So syphilis in the secondary stage is associated with the classical rash, as we have all learned in our UG days, and the meningitic picture in this stage of illness would point to the diagnosis towards acute syphilitic meningitis. The third manifestation could be meningovascular syphilis, which occurs at a later stage of infection, and there can be prodromal symptoms. There can be issues in the form of neuromotor paralysis, headache, psychiatric manifestations. A very important point to remember: neuropsychiatric manifestations in HIV. Think of neurosyphilis. And this is a clinical clue that we need to keep neurosyphilis in mind if you're dealing with neuropsychiatric manifestations, of course, other than PML and the rest of the diagnosis that we have talked about. Focal deficits initially intermittent or progress. Coming almost to the close of the presentation, immune reconstitution inflammatory syndrome occurs during the initial months of ART, may result in the development of overt clinical manifestations of silent and subclinical infections, as restoration of CD4 lymphocytes permits inflammatory response to be mounted against dormant pathogens. But, ladies and gentlemen, the most important issue is iris can manifest left, right, and center. We have seen florid pleural effusions. We have seen florid lymphadenitis. This was such an interesting case that I could not resist the temptation of sharing this case with my PG students. Although this has nothing to do with altered sensorium, so this person developed lower motor type of weakness of the limb following antiretroviral therapy, and we diagnosed tubercular arachnoiditis leading to paraplegia as a manifestation of iris. So cryptococcal meningitis can manifest as iris. These cases are usually more often culture negative. Just one slide I thought I will share on cryptococcal meningitis iris. The inflammatory response is more important than the antigens, and the antigens are usually of the non-viable fungus because they were dormant antigens. So they're associated with higher CSF inflammatory cell counts, and they are frequently accompanied by raised intracranial pressure and focal brain inflammation more often than it was in the initial cryptococcal meningitis episode. So iris cryptococcal meningitis can be more fulminant, more life-threatening, more associated with mortality than the original phase of cryptococcal meningitis. So, ladies and gentlemen, coming to the end of the presentation, we have talked of the neurotropism of HIV. On the left-hand side, we have the early neurological manifestations which can occur, and all of these have been seen. The late or the chronic manifestations are the ones which we are more concerned about. AIDS dementia, HIV-associated neurocognitive disorder, vasculomyelopathy, more chronic. But above all, I think this slide, which I think is my last slide, should be remembered, because if you are treating HIV, your bread and butter is not HIV, your bread and butter is opportunistic infections. The treatment of opportunistic infections is more important than the treatment of HIV. This is something which has to go down to our juniors and our students. Antiretroviral therapy, again, Vibhutida has taught us, antiretroviral therapy is never an emergency. It is always the treatment of the opportunistic infection which saves lives. And let us remember this diagnosis as we wind up this session. And there are more, but if we remember the common opportunistic infections and the common HIV-mediated entities that can lead to altered sensorium, that can lead to function, that can lead to altered personality, that can lead to changes in higher mental function, then these are possibly most important, and these will suffice our purpose. I end with a note of invitation. We are organizing the EPICON less than 2 weeks from now, and I request all our seniors, our juniors, our students and colleagues to join us at Shiliguri from the 7th to the 9th of June 2024. Thank you, Vibhutida.
Thank you, Dipanjan, for taking us through the whole gamut of CNS infections in HIV disease with beautiful slides and illustrations. Just few words for reminding all our viewers that we need to keep in mind in a person, immunocompromised person presenting with altered sensorium, that apart from the HIV associated conditions, they can have other common things like substance abuse, alcohol, head injury, brain tumors, encephalopathies, hepatic and uremic encephalopathies. And among the infections in our country, we must remember malaria. So all the immunocompromised persons presenting with altered sensorium must be tested for malaria. And we should also keep other causes of acute encephalitis syndrome, including scrub typhus. All of us know that scrub is increasing. So we must be keeping that in mind also. And we know that people don't have a mark of HIV in the body. So none will, most of the time, will person is presenting first in his life with a altered sensorium. So we should think when to suspect HIV, like somebody is having cachexia, oral candidiasis, scar of herpes zoster, molluscum contagiosum, some genital lesions. So, we must remember that nowadays we are getting more people in the early stage of the disease, very few people with the advanced disease. That's very important. You have rightly highlighted the rise of syphilis. We are seeing increasing number of people, HIV infected persons with syphilis infection and ocular infection. Ocular infection in syphilis is something which we are seeing. And finally, regarding the brain imaging, we must remember that we should always use contrast. So that's very, very important that whenever we are doing a brain imaging in HIV, we should be always using contrast, because otherwise we will be missing the enhancing lesions. So now we'll be taking the questions in the chat box, mostly put by Professor Shibendu Ghosh. I'll go to the first question to Dipanjan. Of course, you have highlighted the same during your talk, but again, radiological difference between CNS lymphoma and other as well. Radiological difference between CNS lymphoma and other as well. You have talked about that, but would you just repeat that?
Yes, Vibhutida, basically, we have touched upon that point, and we, as clinicians, what we know is primary CNS lymphoma. কয়েকটা কথা মনে রাখতে হবে যে নাম্বার ওয়ান, অ্যাডভান্সড এইচআইভি ইলনেস, there will be no feature of an opportunistic infection in the form of fever, headache, etc. No inflammatory markers will be increased. In the in the imaging characteristics, primary CNS lymphoma, দুটো কথাই আমরা মনে রাখবো। একটা হচ্ছে it is periventricular in location, usually unilateral, and not associated with perilesional edema. So এইটুকু আমার মনে হয় যদি আমরা মনে রাখতে পারি, we can make a provisional diagnosis of primary CNS lymphoma. Rather, Vibhutida, if you allow me, আমাদের কলকাতায় private sector, are we having some access to brain biopsy? If I may ask a question.
You have raised a very important question, Dipanjan. We have been having this issue, but some of the private centers, I should not name them, but I think like INK and others, they are, so they are doing the brain biopsy, and we have had help from them. And sometimes, it becomes an issue when you have a person with HIV infection, but some of the private hospitals are helping us with and we have got very interesting diagnosis. Okay, now coming to the second question by Professor Shibendu Ghosh. When do you start ART in a TB patient? So TB and HIV co-infection. So how do you sequence ATT and antiretroviral therapy?
আমরা যেটা বললাম যে always we have to treat the OI first. So in the domain of TB HIV, you first start anti-tubercular therapy. We wait for a minimum of 2 weeks. If the patient is clinically stable, we can start. The recommendation is to start within 2 to 4 weeks. If the person is clinically unstable or deteriorating, we can wait a little further, but never beyond 6 weeks. So by 6 weeks, we should be starting the antiretroviral therapy, but it basically depends on the clinical condition of the patient. The recommendation is to start within 2 to 4 weeks.
Right. So nowadays the recommendations are moving towards earlier starting of initiation of ART. Maybe if within 1 week also, if the patient is stable, you can think of starting. Okay. Next question by Professor Shivendu Ghosh is role of Indiaic preparation in cryptococcal meningitis. You have already highlighted that, but could you please repeat? Indiaic preparation in cryptococcal meningitis.
India Inc.
Yeah.
India Inc. preparation is more widely available. And especially for us in the government sector, India Inc. preparation is easy to order from the microbiology department. But cryptococcal antigen in should be available. And maybe I should add a point that point of care testing is now available in many of the corporate hospitals. So these point of care testing machines has their own chips and their own diagnostic cards. So we can actually diagnose cryptococcal meningitis with cryptococcal antigen, serum cryptococcal antigen in the wards.
Yes. You have rightly pointed out that lateral flow assay kits are available. So we should be making this more available to the centers where they are seeing these cryptococcal meningitis and in fact throughout the West Bengal. The next question he has asked is that people in northeastern states are using doxycycline in AES cases, acute encephalitis syndrome. So what is your take on that?
Doxycycline in the setting of acute encephalitis syndrome is a national recommendation. So I think without getting into opinions, we have to administer. Possibly it is rational because doxycycline is one cheap antibiotic which doesn't cause harm. Rarely it would be contraindicated if the person is having advanced jaundice or maybe pregnancy. Otherwise, doxycycline is a safe drug and doxycycline has several advantages. And especially in a country where the diagnosis of scrub typhus, even in centers where it is available, takes more than 24 hours or sometimes 48 hours, I think doxycycline must be administered because it's a life-saving drug in the setting of scrub typhus.
Yeah, because we know that in a study by NIMHANS, which involved North Bengal Medical College, Bardhaman Medical College, and Bankura Medical College, they studied cases of AES and they found that more than 33% cases of AES were due to scrub typhus. This is the most common cause of AES. So as you have rightly said that we should be using doxycycline initially intravenously if the patient is very sick and then orally we can give that. And his last question is, he has asked that is dementia more common in immunocompromised patients without CNS involvement? Is dementia more common in immunocompromised patients without CNS involvement?
To be honest, we don't see much of dementia in our clinical practice. Means even when I have come to North Bengal, our ART center has more than 4,000 PLHIVs. I don't think much of any of our juniors will remember a lot of dementia in the HIV context. So dementia per se is a rare diagnosis, and it would be wrong to say or wrong to comment whether the prevalence of dementia is more or less in the setting of other neuro-HIV affliction. Maybe Vibhutida will be able to shed some light. Dementia per se is a rare diagnosis in HIV.
Our very senior, I want to intervene. Our very senior neurologist, Dr. Bhaskar Ghosh is there. I think this should be answered by him.
Sir, please.
I will talk after Vibhutida.
Okay.
Please. Bolun.
I think as far as my knowledge goes, we have seen so many dementia patients, but in none of the patients get HIV positive. So I don't think that, as Dipanjan is telling, that there is much prevalence of dementia in HIV patient in comparison to general population. This is my take.
Yes. So as Dipanjan has already pointed out, we previously we said this as AIDS dementia complex. Now it comes under hand. So they will have a component as a part of the brain affection. So without brain affection, dementia, I think we are not seeing that. So we have taken the questions in the question answer box. So the faculties are there. So if you have any questions, you can
Yeah,
ask to
I have a
Dipanjan.
comment due to that.
Sir.
As you have shown us some cases of acantha amoeba, that is Naegleria fowleri. So one
Yes, sir.
condition that is amoeba granulomatous infection due to acantha amoeba. So that is probably common in immunocompromised host, but it is itself Naegleria fowleri infection is uncommon. But I think nowadays, as you have shown few cases, we are acquainted with the disease. So I think it should also come in one of the causes of opportunistic infection.
Yes, very rightly pointed out, because previously we saw Naegleria fowleri, and nowadays we are seeing primary iambic encephalitis. We have seen a lot of cases in Kolkata and around by various centers. We have seen more than 30 cases recently, and they are known to be occurring in immunocompromised patients. But we have come across only one HIV patient with primary iambic meningoencephalitis, but most of them have other diseases, including tuberculosis and other things. But as Bhaskar has rightly pointed out, that we should be keeping this in mind as an upcoming condition which can cause alteration of consciousness in a PLHI. We should keep it. And the diagnosis is very simple. You take CSF, do a hanging dog preparation, and you can see the mobile amoeba. So that's how you diagnose this. So any other questions by anyone? Comments, questions?
Dipanjan,
হ্যাঁ স্যার বলুন।
very beautiful lecture, but problems very often come that how I will differentiate that this unconsciousness is due to infection or due to non-infectious cause. This is our primary goal. Can you suggest some pointer, both clinically and through simple investigation, so that we will point towards infection?
স্যার কোয়েশ্চেনের শুরুটা কি ছিল?
Yeah, how will you differentiate at first sight that this cause of unconsciousness is non-infectious or due to some infection cause, which is very common in the immunocompromised host?
Sir, I think the question is very clinically important.
হ্যাঁ।
কেননা আমরা যখন অল্টার্ড সেন্সোরিয়াম পেশেন্ট পাই, আমাদের তো একটা বড় চাঙ্কি হচ্ছে নন ইনফেকশাস।
Non-infectious.
That can be alcoholism, it can be alcohol withdrawal, it can be vascular disease, cerebrovascular, it can be traumatic, it can be metabolic.
Which are
আমাদের তো অনেকটাই নন
which
ইনফেকশন।
are very common in the HIV patient. Drugs.
আর এইচআইভি পেশেন্ট যদি বলেন স্যার, যেটা বিভূতিরাও হাইলাইট করছিলেন, যে এইচআইভি পেশেন্টরা হাইপোগ্লাইসেমিয়া হতে পারবে না বা ডায়াবেটিক কিটোঅ্যাসিডোসিস হবে না, এমন তো নয়। সুতরাং আমাদের একটা মোস্ট ইম্পর্টেন্ট ইস্যু ইজ ফিভার। সো ফিভার উইথ অল্টার্ড সেন্সোরিয়াম শুড বি ইম্পর্টেন্ট। যতগুলো আমরা ডায়াগনোসে আলোচনা করলাম, ইনফেকশন গুলো সবগুলোতেই কম বেশি ফিভার থাকে। আর মেনিনজিয়াল সাইন্স যদি থাকে, তাহলে স্যার ইট গোজ মোর ইন ফেভার অফ আ মেনিনগোএনকেফালাইটিস।
ব্যাপারটা অনেক ইজি হয়ে যায়।
সো আমাদের সবকিছুই হতে পারে। যেমন বিভূতিটা বলছিল যে এইচআইভি পেশেন্টের সেরিব্রাল ম্যালেরিয়া হতে পারে, তেমনি এইচআইভি পেশেন্টের স্ট্রোকও হতে পারে। আজকালকার দিনে স্ট্রোক
কমন।
সো কমনের মধ্যে স্যার আমরা যেগুলো আলোচনা করলাম, এইচআইভি পেশেন্ট যদি পাই, আমার মনে হয় দ্য ফার্স্ট ক্লু, ইফ ইট ইজ আ এইচআইভি ইনফেক্টেড পারসন, we should think of an infective cause of altered sensorium. A HIV person presenting with a non-infective cause of altered sensorium is per se relatively rare. তারপরে তো কিছু কিছু ক্লিনিক্যাল ক্লুজ আছে in the form of fever, meningeal signs, rash, lymphadenopathy, etc.
Is prolactin helpful?
No, prolactin is not nowadays.
That prolactin possibly not, because
No.
prolactin, Vibhutita will have the final say, but prolactin is more related to our bacterial sepsis. So আমরা যে ভাইরাল ডিজিজ গুলোর কথা ভাবছি বা অপরচুনিস্টিক প্যারাসাইটিক ডিজিজ গুলোর কথা বলছি, they would possibly not be much leading to a much hike in prolactin levels. Vibhutita?
Thank you.
স্যার বোধহয় প্রোক্যালসিটোনিনের কথা বলছিলেন স্যার?
হ্যাঁ, প্রোক্যাল।
স্যার প্রোক্যালসিটোনিন বলছেন। প্রথম কথা হচ্ছে প্রোক্যালসিটোনিন স্যার একটু এক্সপেন্সিভ এবং রিপোর্টটা তো পেতে সময় লাগে। Dipanjan যেটা বললো স্যার, I মানে stress again on that clinical evaluation of the patient, তার কোনো র্যাশ আছে কিনা, এসচার আছে কিনা, কোথাও কোনো সিফিলিসের কোনো মার্ক আছে কিনা ইত্যাদি গুলো দেখা, এবং নেক্সট স্টিফনেস, নেক রিজিডিটি ইত্যাদি দেখা, এবং তার ইভ্যালুয়েশন কাউন্ট, সিএসএফ করে আমরা তো উইদিন 1 day উই ক্যান গো টু দ্য ডায়াগনোসিস। প্রোক্যালসিটোনিন স্যার পাঠিয়েও রিপোর্ট আসতে তো 3 4 দিন সময় লেগে যায়। বাই দ্যাট টাইম উই নো হোয়াট উই আর ডিলিং উইথ অ্যান্ড উই ক্যান ম্যানেজ দ্যাট অ্যাকর্ডিংলি স্যার।
Yeah, actually, just I want to add a point that when we
Yeah.
get a patient in a unconscious state or altered sensorium state, we should go for in a normal patient. We should not think of the patient has got HIV. And if you have
Sure.
got some clue that infection is there, then it's obvious. But I think neuroimaging and a good CSF study will help you a lot in overcoming this problem if it needed.
Sure. Sure.
হ্যাঁ, ভাস্কর দা, শুধু একটা কথা বলবো যে আমরা যখন সিএসএফ স্টাডি করব
Mhm.
তখন কিন্তু এইচআইভি পেশেন্টের হলে সিএসএফ এর প্যারামিটারস গুলো একটু অন্য পাঠাতে হবে, মানে রুটিনলি কি আমরা
Definitely,
কক্কাল
definitely.
পাঠাবো? তো সেই জন্য ওই এইচআইভি ডিজিজটা আছে কিনা জানলে একটু সুবিধা হয়।
Yeah, Seta, definitely that you have to know. That what I am telling that a HIV patient may have features like a normal patient. That's
হ্যাঁ স্যার, হ্যাঁ।
Thank you for excellent lecture. I think I have never heard such a beautiful talk. It cannot be better than this.
Okay, thank
একটা কোয়েশ্চেন এসছে, সরি স্যার, আরেকটা কোয়েশ্চেন এসছে সিআরপি নিয়ে একটা কোয়েশ্চেন এসছে। দীপাঞ্জন,
বলো।
রোল অফ সিআরপি নিয়ে একটা কোয়েশ্চেন এসছে চ্যাট বক্সে, কোয়েশ্চেন আনসারে, তুমি কিছু বলো যদি। রোল অফ সিআরপি।
রোল অফ সিআরপি, আসলে এইচআইভি being a state of chronic infection and inflammation, all our inflammatory markers are relatively insensitive because in HIV setting we are already dealing with a state of chronic infection. এটা নাম্বার 1। যদি এইচআইভি ভালো করে, if the HIV is well controlled, then the chance of opportunistic infections are as it is less. So when we are having opportunistic infections, it is difficult to depend on ESR or CRP. Even it is even less dependable than in the immunocompetent population. This is my personal opinion, Vibhutida.
একদম একদম, শুধু একটা কথাই বলা তোমার সঙ্গে, যখন কোনো কারণে ম্যাক্রোফাজ অ্যাক্টিভেশন সিনড্রোমের কথা ভাবছি তখন ভেরি লো ইএসআর, যেমন আমরা সিএম ভ্যানিকুলোপ্যাথি উইথ ম্যাশ পেয়েছিলাম তখন। আদারওয়াইজ কিন্তু রুটিনলি অ্যাজ দীপাঞ্জন সেড সিআরপি তো এদের বেশি থাকবে, ইনফ্লামেশন থাকে বলে। স্যার আমাদের মনে হচ্ছে না আর কোয়েশ্চেন আছে, এবার যদি আপনারা স্যার।
রবিবার তো।
Thank you.
হ্যাঁ সেই বলছি, এবার স্যার দেন স্যার।
Our last ritual is the chairman's remark. If you have anything add or comment, you can perform it. Then we will do the last ritual. Please give your comment.
So it was a wonderful presentation by Dipanjan, and there will be very nice interactions from various persons. So all of us, I think, enjoyed. We are waiting for the remark to hit us. বাইরে তো খুব হাওয়ার আওয়াজ পাচ্ছি। তো anyway, we all enjoyed, sir. So that's all from me, sir. Thank you.
Thank you, Dipanjan, for double century.
Thanks. Now I request Dr. Harishankar Pato, who is a governing body member of API, to give vote of thanks.
At the outset, I thank Dr. Amal Kumar Banerjee, Chairman ICV Forum West Bengal, for giving me this opportunity to present the vote of thanks. Next, I will thank Professor Vibhuti Saha for conducting the session through our session very nicely. He is a polished regarding this managing all these programs and seminars. And I also thank Professor Dipanjan Bandyopadhyay for his very comprehensive and very exclusive talk on this topic. After so many months, I could hear such a good lecture. And I pity for those students who could not attend such an excellent teacher's lecture and program. I thank all the program directors, particularly Dr. Satyabrata Ganguly, for devoting so much time and organizing all these classes regularly. I thank all the participants, postgraduate students. I will fail in my duty if I do not thank Dr. Shivendu Ghosh for asking maximum number of questions in all the master classes. And thank you, everybody. So over to our chairman.
সবাই শিলিগুড়ি আসবেন।
Okay, thanks. I think many people, round about 80 doctors will go to Shiliguri as far our knowledge is concerned. Anyway, 80 people will go from Calcutta to Shiliguri to the GCDC SAPICON. One thing I should comment before finally I conclude this session. Today's session is particularly for the immunocompromised patients. We should remember first an immunocompromised patient with altered sensorium, and we should try to find out the possible differential diagnosis in that light. Not that a patient with the normal immune function, but immunocompromised patient. And Dipanjan is very aptly discussed all the issues with the very masterly help and suggestion from Vibhuti. Now we are going to adjourn this master class till the 16th of June, when we will have the next master class on approach to tachyarrhythmia. Thanks to all. Now we are going to close this session. Thanks.